I want to welcome you to our webinar today, Patient-Centered Medical Home Updates for the Safety Net. And this production is of the National Healthcare for the Homeless Council, which is made possible by a grant from Health Resources and Services Administration, Bureau of Primary Health Care. This is a one-hour presentation with the last 10 minutes reserved for question and answers. At any time during the presentation, you may type your questions for our presenters in the chat box below the presentation slide. Questions will be answered at the end of the presentation during the Q&A session. This webinar will be archived on our website at www.nhchc.org within 72 hours. If you're experiencing technical issues, please call Sarah at 615-226-2292. Thank you once again for joining us to learn more about the patient-centered medical home for safety net providers. And I do want to let everyone know that we have done a series of webinars over the past 2 years with case studies of other healthcare for the homeless grantees who have become recognized in the patient-centered medical home. Today, we have speakers from the NCQA to speak specifically about the patient-centered medical home standards recognition process and changes that have occurred in the 2011 standards. So, our speakers today are Mina Harkins. Ms. Harkins is with the National Committee for Quality Assurance, NCQA, as Assistant Vice President, Recognition Programs in Washington, D.C. In this position, she is responsible for the operation of all recognition programs and the new ACO accreditation program. The recognition programs are focused on quality management of chronic conditions such as diabetes and ischemic vascular disease, and the systems and processes utilized in a clinical practice, including the patient-centered medical home. Before joining NCQA, she worked with the Laboratory Accrediting Organization, administered a large anatomic pathology operation, managed a number of departments in a multi-specialty group practice, and managed a multi-site laboratory operation for a staff model HMO. Ms. Harkins earned her BA in Medical Technology at the University of Pittsburgh and her MBA at Johns Hopkins University's Carey School of Business. Tanya Medrano, our second speaker, is Outreach Manager for the Government Recognition Initiatives and Projects, GRIP, unit at NCQA. Ms. Medrano has been with the NCQA since 2000 and has served in various roles in NCQA's accreditation, marketing, customer outreach, and physician recognition departments. She is responsible for developing and executing outreach activities aimed at promoting the medical home concept in federally qualified health centers and military facilities. Ms. Medrano earned her BS in marketing from the University of Maryland University College. I am now thrilled to present both our speakers, and I will hand the mic over to Mina Harkins. Thank you.
Thank you very much, Anna. And this is Mina. Tanya and I are very pleased to be with you today to give you some additional information around NCQA's program. We're going to be addressing with you some of the goals of our patient-centered medical home program. As we call it, PCMH 2011 is our second version of the requirements that we use at NCQA to evaluate clinics and practices for recognition in our program. We're going to talk a little bit about the survey and application process for eligible practices that can participate under the HRSA grant. And then I'm going to, we don't have time in about 45 minutes to give you a training from soup to nuts, so I'm going to highlight some challenges and opportunities that we've identified that I think will be particularly relevant to your practice setting. So just a brief background on NCQA to understand. We've been working in the quality sphere for over 20 years now with a vision to transform healthcare through quality measurement, transparency, and accountability. We have over 30 programs now that do evaluate different types of care programs, case management, clinician recognition, wellness programs, all with the goal of improving the quality of healthcare. Now, when we started in the patient-centered medical home area, we worked closely with those primary care organizations that created and endorsed the joint principles of the patient-centered medical home. And this was focused on transforming primary care into what patients want. This is an opportunity for patients who are having that first contact with either maintaining their health or taking care of a chronic or acute condition to get them started with whatever kinds of care need to be coordinated. And so it's important that they build a relationship with the provider and the care team, that they have access through expanded hours so that they're not getting care that is isolated by getting care from different providers in different locations that don't talk to each other, but also sharing decisions with the patients or the patient's family so the patient is more engaged and has more information to help them make informed choices. This model of care has begun to show some benefits and lower costs, especially from reduced emergency department and hospital use. And there's a benefit, too, to the participants in a patient-centered medical home, that there's more satisfaction amongst the providers and the care team as well as with the patients. Where we started along this road was with the early Institute of Medicine's Crossing the Quality Chasm, and they presented these 10 simple rules for the 21st century healthcare system. And we do believe that the patient-centered medical home makes great strides towards achieving this type of healthcare system. We've seen and looked at examples in other countries where in some cases they've eliminated just large numbers of hospitals because care is so well coordinated on an outpatient basis that there is less need for either readmissions or hospitalizations in the first place, because patient care is coordinated and evidence-based guidelines are used. There's an anticipation of what the patient will need and a coordination amongst all the participants in the healthcare arena that'll take care of that patient. We also want to keep a focus on the triple aim, or the three paths, or the triple path, however you want to refer to that. And it allows us to follow the mantra that Don Berwick, who was first the president and CEO of IHI and then briefly named to head CMS, he led much of the emphasis on patient experience. And these three dimensions are improving the patient experience of care, so improving quality of that patient's care and their experience with it, improving the health of populations by really utilizing the large amounts of data that practices have always had, but perhaps not had a way to use it efficiently. And that allows us to address things that are needed in populations of patients, whether they're an age group of healthy patients or a group of patients with a chronic disease, where we might be tracking them through a registry or an electronic health record. And then reducing the cost of health care through this better coordination of the needs, of meeting the needs for those patients. And we have embedded these throughout NCQA's requirements. Now, I have noticed that you've had some previous presentations on meaningful use, and so those of you that are familiar with the requirements in Stage 1 and now coming up on Stage 2 for meaningful use will know that it was intended to help organize around this information-intensive environment that you work in and learn how to use that data meaningfully to improve quality. So we embedded meaningful use into our standards so that those things that you might already be pursuing for meaningful use also contribute to your capabilities to function as a medical home. So where they fit, we engage the meaningful use objectives right in with our standards and requirements. Now I'm going to have Tanya give you some information on these federal initiatives.
Thanks, Mina. Thanks, everyone, for joining us today. I'm going to talk briefly about the HRSA initiative, which is one of three federal initiatives that's managed by my department, the Government Recognition Initiatives and Projects Unit here at NCQA. The HRSA program, or as we refer to it, HRSA Patients in the Medical Health Home Initiative, began actually in 2010, and this program is geared toward giving assistance to community health centers that serve the rural and underserved population, often led by often in the population of nurse-led practices. Excuse me. So with this initiative, health centers can receive funding provided by HRSA that covers the cost of PCMH recognition, and we also provide technical assistance through this program. Again, the program began in 2010, and in each year we have available spots for up to 500 approved health centers to come through this program, and it is a 5-year contract. To date, we actually have updated the slides as of this morning. So we have recognized 292 health centers to date through this initiative. And as mentioned before, this is managed by my unit, which is the GRIP unit. So again, with this initiative, the cost of survey or going through survey to achieve PCMH recognition is covered by HRSA, and that entails the cost of the actual survey tools and application fees. So for those that are in the initiative, these are costs that you don't have to concern yourself about because they are provided by HRSA. And as far as for those that are interested in applying, the application process is actually very simple. You only have to complete a one-page notice of intent that is available on HRSA's website to apply for the initiative. And within the NOI, you list information about your health center, how many if you have more than one site, how many sites that you would want to bring forth for recognition, and also you indicate your timeline as far as when you feel that you will be able to undergo this process. With the mindset that HRSA ideally wants all approved centers to come through the process within a 12-month time frame. Through this initiative, we do provide technical assistance in the form of monthly trainings. The trainings cover the PCMH 2011 standards, as well as the use of the online application and the interactive survey system, or our ISS system, which is the platform for the web-based survey tool. Again, these are all a part of the initiative and are provided at no cost. Additionally, we also offer mock surveys to participants in this initiative. Mock surveys are a great resource and technical assistance that centers can use to give them an idea of how they would score and how they're meeting the standards without actually going through the formal submission. The way the mock surveys work is that once we have a request from a health center that's interested in going through a mock survey, we contact them and work with them in meeting the criteria. One of which is completing the actual readiness assessment, which is within the survey tool, and also having completed and have supporting documentation available to be reviewed by our trained surveyors. Once the review is complete, the review actually takes about 1 to 2 weeks to do. And actually what happens is, unlike a formal submission where you're actually submitting the survey tool, our surveyors actually are assigned a user ID to access your survey tool, and they review your information that way. Again, once the review is complete, NCQA schedules a post-conference call with the health center where we actually go over the reviewer's findings and at the opportunity give the health center the opportunity to ask questions and go over the final results at that point. So again, it has been a great resource for many of the health centers that have come through this initiative. So just give you some information about the survey process. One of the things that's often asked is for those that are interested or those that are just joining the initiative is how long does it take to prepare? And actually, it really does depend on where the health center is at their time of application, and also what their current ability is to function as a medical home. But we say that as far as being prepared, that the health center must have a minimum of 3 months experience with policies, procedures, and documentation to support that, to even be considered to apply for the initiative. We have a lot of health centers that want to come through the recognition, and they may have multiple sites that some sites that aren't even open yet. And so, we tell them again the center has to be open for at least 3 months so they can have the 3 months experience and data that's required to go through the process. What we found out is that most sites from start to finish, it takes them about a year to actually come through the process, and that actually coincides with the expectation for HRSA, as I mentioned before, that once a site is approved for the initiative, ideally their timeline is to have the center to submit for recognition within 1 year. As far as completing the survey, you'll be completing information on the online application as well as the survey tool. And this is the feedback that we've gotten from health centers that have gone through the process. And again, it may vary depending on how your systems are in place, but approximately it takes about 80 hours of staff time to complete the actual survey tool prior to submitting to NCQA. As far as gathering and having the appropriate documentation, that actually may take a lot longer. Again, we're looking at somewhere between 3 to 4 months to have just everything ready to be loaded in the survey tool before finalizing your survey submission. So I'm going to turn it back over to Mina to discuss Must Pass Elements.
Yes, so where to get started? Tanya's given you an overview of the steps that you might be taking to start getting your changes into place. Most clinics and centers don't start out as a patient-centered medical home. There are lots of definitions and requirements out there. Now, NCQA's requirements, as I said, do follow the endorsed principles of the patient-centered medical home that are looking at increased access, using data for population management, care management, supporting self-management, tracking of tests and referrals, and performance measurement and quality improvement. So if we look at these must-pass elements, the 6 areas of our standards and requirements do reflect one must-pass element in each of those areas. And so with our limited time, I thought it was best to focus on the kinds of things that you really need to get started on in order to assure that once you are ready for submission, that you've covered the must-pass elements in the critical areas. These must-pass elements were selected so that every patient-centered medical home that becomes recognized, we have 3 levels of recognition depending on the number of points that you achieve through completing the various requirements. But to achieve any level of recognition, you do need to score 50% of the scoring available for each of these must-pass elements, and they allow that there's some standardization of recognition. You now know then that any NCQA recognized medical home will have access to same-day appointments. They'll have an outreach program that utilizes the data within their systems to reach out to patients for both preventive and chronic care activities that need to be addressed. That their care management uses evidence-based guidelines, and there's proper documentation of that care management and care plans for the patients. That they provide a certain level of self-management support then for patients either in their health maintenance or in their chronic conditions or their behavioral health. That has also been pulled into the patient-centered medical home, recognizing that there are many aspects of health of the patient's health that are affected by their behaviors, whether they're healthy or unhealthy, and what mental conditions might also be contributing to a patient who's perhaps in a complex or high-risk category. And then in the areas of tracking, we know that most places do track their labs and imaging to make sure things don't fall through the cracks. And so we really focus now in 2011 on the referral tracking and follow-up, closing that loop, not just seeing that the patient got the appointment, but that the information came back to the care team on what that referral was to answer for that patient's care. And then in the areas of performance measurement, seeing that all sites know how to use measures within their processes and operations to make improvements in the care of their patients. So not just putting out data reports, but utilizing that data to recognize where they can get better results and implementing action plans to make those results. So let's look at a couple of these areas today and see where we can help you with getting down the road to recognition with NCQA. And I hope that you all do make the effort to get a free copy of the guidelines. It costs you absolutely nothing to go to NCQA's website and place an electronic order, and you'll receive it back within a very short period of time. And you'll have then an electronic copy for your use of all of our requirements. So I'm going to refer to them kind of by their acronyms, but you can use those guidelines then to focus in on and applying some of the tips we're going to share with you today. In PCMH 1A, which you noted was the must-pass element on access during office hours, there is a critical factor. We just kind of called them critical factors because these two particular ones you must have in order to pass those must-pass elements, and you must pass all the must-pass elements to achieve recognition. So this is a place that you have to put some effort in seeing that you've met these requirements. So providing same-day appointments is the critical factor within that access during office hours. And we are not prescriptive, as you'll find when you read through those explanations. We say that they should be available across the practice. They don't have to be on every single provider's schedule, but you need to have same-day appointments for both routine and urgent care available every day for your patients. This is going to keep them out of the emergency rooms. This is going to keep them from having conditions that get worse because they couldn't get in when they needed to. So this is really the patient-centered focus of access during office hours. And then in Factor 4, which is patient self-management support, you'll be doing a chart review, and I'll get give you some information about that in a moment. But in that element that looks at self-management support, the critical factor that's there that you must have to pass is developing and documenting a self-management plan and goals for that patient that you've established in collaboration with the patient. And within that chart review, you'll need to have had documentation for 50% of the patient sample you're going to look at that you have completed this kind of self-management plan and treatment goals for that patient. What is the patient going to do when they go back home? Are they going to have tools? Are they going to have a written plan? Are they going to know that they're going to show up for their smoking cessation? They're going to show up for their exercise. They're going to chart their blood pressure every day. What are the things that the patient needs to be engaged in to help them reach a healthier state? So these are good places to begin, and as I said, you can't achieve recognition without them. Now let's talk just a moment about that record review workbook. It is the only documentation that you need for 3 of the elements. However, it is a sample that has very specific instructions. This workbook is in the survey tool, so as soon as you engage with your notice of intent and get that processed through to NCQA, they'll be providing you with this with a survey tool, and in there are 3 factors that this workbook is made available for documentation, and so you can download it to your own computer from the survey tool. It is an Excel workbook, and it has 3 tabs. If you're familiar with Excel, one has a complete set of instructions, but we also have a very nice recorded workshop on our website that walks you through how to use this workbook. And we've got great reviews that it's extremely helpful. It's there anytime you need to refer and get a little help in understanding the rather extensive instructions that are provided in that workbook. It does tell you that you are going to be selecting a sample of 48 patients in each of your clinic sites, and it doesn't matter who they saw, but they're going to be based on a number of important conditions which you've identified in element 3A, which is focused on evidence-based guidelines. And we just wanted to point out as something to refer back to here and say you remember you heard something about this, is that one of the 3 conditions must be an unhealthy behavior, a mental health condition, or substance abuse. And so of the 3 conditions, and then there's also a group of high-risk or complex patients that you identify in element 3B. So there are 4 populations of patients with various conditions that you're going to be selecting from in order to do your record review. And we just find that a lot of practices kind of miss, say you decide you'll just start out with 1 or 2 conditions and try to go for level 1, just pay attention to the instruction that whatever number of conditions you start out with, one of them must be that unhealthy behavior that's factor 3 in element 3A. Otherwise, you will not be able to pass 2 of the must-pass elements that the documentation that you're providing is going to be this record review workbook. So just as a little summary, there's a record review workbook that's in the survey tool. It's going to be a chart review of 48 patients. The instructions are there. Just remember that one of the conditions that you need to identify and use for some of the patients and for demonstrating your use of evidence-based guidelines must be that unhealthy behavior, mental health, or substance abuse. Now, Tanya mentioned you will need documentation for your submission or even for your mock survey, and that's kind of the thing that takes the time to get all of your materials together. And so all of these must-pass elements do require some data, but none specifically require the use of an EMR. So a practice can achieve recognition without an EMR, and I know lots of the health centers have spent a lot of time and gotten some assistance in implementing electronic health records, but we do just want practices and clinics to know that you can achieve recognition probably at level 1 without an actual clinical health electronic record. The must-pass elements don't really require that EMR except for the element 2D that is on population management, but you can sometimes pull the data, the list of patients that you need for that from a practice management system or billing or appointment system. And so that's kind of the most electronically based of the Must Pass elements. All of the others do require reporting of information, but you will be able to construct that without the EHR. But there is quantitative data, and I've noted in 24 of the 28 elements. And so, you know, the more that you can make use out of your health information technology is going to get you far down the road towards your higher levels of recognition. Now, not only in your own system, but, you know, getting assistance for providing some of the reporting can come from external sources as well. Now, if you are utilizing external sources, we do expect that that data that they provide perhaps on performance measures or patients in a registry, they do have to cover at least 75% of the clinic's population. So if all that information is coming from one payer, that payer's patients need to represent 75% of your patient population. So if your patients are largely uninsured or covered by Medicaid, you'll just need to, if you're utilizing an external source, make sure that it is covering, you know, that majority population. And these are a lot of places where data might be collected or reported to these entities, and so any of them that you can get data from. Also, physicians that are participating in getting their maintenance of certification for their medical boards. Sometimes they're doing reports around performance measures. And if you can't just use a single physician, though, you will, again, if you have multiple clinicians, have any individual clinician reporting will have to be presented for 75% of the clinicians in your patient population. Some of our recognition programs that your clinicians may be recognized in, such as our diabetes or our heart stroke program, if they have achieved individual recognition, you can use that as for some of your performance reporting. But again, it needs to be 75% of your clinicians need to be represented in that recognized group. Now, we try to focus on some of the special populations, and we understand that this group certainly has a special population in the homeless area. And there are some challenges because of that, that you have to deal with transient populations trying to get the patient to have some continuity. There have been some studies on you know, programs that utilize residents and others or part-time physicians where you can't really have every patient appointment with the same actual clinician. And in those cases, we found that it's important for you to really build that strong care team, because sometimes it is the care team that provides the continuity for patients who have some variation in the providers. Now, on the patient side as well, if the patients are going in and out of various systems, then, you know, the challenge of patient engagement and keeping them engaged with a care plan and a care team is really difficult. So you need to have a process and a plan, and we've added a requirement around helping patients understand what a patient-centered medical home is and how their engagement is a key part of maintaining their health. So providing patients with that information and how they need to participate, being able to do it in a culturally and linguistically appropriate manner, having outreach programs that look for patients that have missed appointments or have fallen out of the system are all things that are embedded in the program. And so these requirements can really help you with you know, having more continuity and less disconnects with that kind of transient population. So there are lots of opportunities to improve that patient engagement. We've given you some examples here, and you'll find them throughout the standards. Bringing patients in for group classes, finding qualitative means to get patient feedback that's really connected to their circumstances. So, trying to bring in a group of patients and have a focus group on, what do they need? What do they need out in the community so that you can help identify resources that will keep them connected with your health center. The slide here just gives you some resources for patient self-management. I encourage you to utilize, not only these, but other community resources that are available for engaging the patient in their care. And connected to this then is being able to measure how well you're doing with some of these aspects. And we've learned that although you might have some standardized reporting that you're obliged to provide, you really need to use that data and look at your current performance. Is it jumping around all the time? Is it controlled? Do you have plans to make improvements where you've identified gaps? And so it's going to help you on your performance internally, but there's a lot more demand these days for external accountability, decision-making, public reporting, and evaluation. And so, HRSA is looking very closely at what level of recognition the practices are getting, and there is the opportunity for what we call an add-on survey as well, so that, if you start out at level 1, you can get support through the HRSA grant to do an add-on survey when you're ready to report on perhaps a higher level of meeting the more of the requirements. So, how to get started is always a challenge. You've got to engage your whole clinic, your practice staff, and the patients. Some of these qualitative analysis, we call it, meaning it's not numbers. What alternatives can you use by, talking with the patients and finding out alternative means of getting them some of the services they need. If you have identified some processes that aren't working well, and this is one of the reasons for the 3 months that we ask to have things in place, so that you've kind of shaken them out to see what they might be flawed. I mean, we're not all perfect with what we have great ideas sometimes about what to implement, but occasionally, you find that, some key piece got missed or didn't engage one group that are really important. So, you've got to find methods that the team can use to identify those and work with the patients to get better buy-in from the patients. And so a lot of communication is really needed to get these activities off the ground. You should recognize that changing behavior isn't easy, but you do have more control on your internal staff than on your patients. And so sometimes you need to focus on those things first and then talk about things that are going to require the patients to be really engaged and participate with you. When you're implementing actions to make these improvements, you need to look at templates and processes and training. Training is really important to ensure that staff and providers know the processes. You'll find in much of our documentation we ask for a documented process. And getting those steps written down provides you with a format to train people against. And then if you have any changes in staff, you've really got something for the next person who's going to be trained in an area to find the details and the sequence that they need to go through, whether it's your referral testing or you're tracking outreach to patients, pre-visit planning, whatever the activity is, having that documented process really helps. Creating groups within your clinic to provide perspectives on how, different ways that they've found, maybe from other sites that they've worked. It's always useful to, kind of engage everyone's experience. That's one of the beauties of diversity, that you get different perspectives and different points of view. When it comes to patients, you're going to have to find a variety of methods to encourage patient compliance. So talking to patients about what works, talking within your care teams about a successful patient. We always find when we go out and do training that they like to have someone from a successful implementation, and I've noted that you've had practices and clinics that have achieved recognition come and talk to you. Use that same model within your patients and your care teams to share what has worked with them. So over time, we've learned quite a lot about practice change and this whole idea of patient-centeredness and whole person care, enhanced access, performance measurement means a lot of change. It needs to take place within your practice. So these are just some of the points that you're going to need to cover. So when you get a group together over lunch or at a project team meeting, start talking about, what are you going to establish for your performance measurement and improvement? What kind of committee, and how can you engage patients? What are you going to do for patient experience? All of these things need to be in place to meet the various requirements. And so, you've got to make a plan and then plan your changes so that you can implement them. Your practice, we call it, is really a system. And it's interesting that when the National Quality Forum evaluated our patient-centered medical home programs, they call it a practice systems evaluation, because all of these things are processes or systems that you are implementing. And in any kind of quality improvement activity, you'll find, you make you look at the goal, you make the change, but then you have to remeasure. You've got to see what is it going to take to sustain that change. And lots of breakdowns occur because we haven't considered the communication or the training. So there's really a technical side to managing change that's important, and involving all the people on the team and including the patients, because that's what's going to make that change successful. To really look at your clinics as a system and look at everybody's role in that in those changes that you need to implement. So I'd like to just point you to a few other resources on NCQA's webpage and on other organizations like the American Academy of Pediatrics, the Medical Home Clearinghouse. And there's quite a few out there that can provide you tools and templates. We've recently seen a new policy and procedure publication from MGMA that is modeled on our various standards and provides you with templates. As I said, you can use our diabetes and heart stroke recognition, and some of the details around that. We have a number of FAQs that you can use, and just some recognition of using your patient-centered medical home recognition for your family medicine providers for their maintenance of certification. So lots of resources are available, and I realize I didn't put NCQA's website on there, but it's just very simply, www.ncqa.org. When you get to our website, we've got a tab there for clinicians, and it'll take you to the medical home website. And we have a couple of videos on there, and we've also found in the social media a couple of medical home training videos that play on YouTube. So, you know, it's really wonderful that there's a lot of resource available out there now that provides you with tools and templates. This one I'm showing you is it's good for providers that kind of don't understand what the medical home is and what, you know, really understanding each of the each of the standards from the provider's point of view. It's done by a family medicine provider.
So our last slide just talks about how you can contact NCQA if you have questions or for more information. Our main forum is our customer support, which information is listed there. You can, as Mina stated earlier, get a copy of the standards for free. You can request it either through our customer support by contacting them at the 188 number that's listed on this slide, or you can also do it by visiting our website and getting an electronic version of the standards for free. You also can contact our customer support if you are already a customer but have questions about maybe you've lost your login information to access the survey tool, or you need to get information about the link to the ISS system. Our customer support representatives are here to help you and can assist with that. My department, again, GRIP, has a portion of the NCQA website that's dedicated for our program, and so on our website we have information for all of our initiatives, including the HRSA program. And you can find information, including our training calendar. You can find information. We have FAQs, posted there that pertain to the initiative. And our training calendar is currently posted for the first quarter. And so that is updated on a quarterly basis. But right now our training calendar has dates up until March. And that is on the GRIP website. How you can contact us at GRIP if you have questions that pertain to the initiative, if you're interested in joining, you can contact us at the email address pcmh-grip@ncqa.org. This is a dedicated mailbox just for all of our federal initiatives. The mailbox is monitored, and we have a one-day turnaround time. So someone is always monitoring that mailbox. So if you have a question, again, that pertains to the standards, once you've had a chance to review them, if you have a question, something you may not be clear on, or questions about documentation, those can be submitted there. You also can use this mailbox to submit your request to attend any of our monthly trainings, as I stated earlier, that are provided through the initiative. You simply just, after you have viewed the training calendar, you can send a request to the mailbox stating that you want to be registered for a training, and we will respond accordingly. At this time, we'll turn it back over to...
Let's turn it back over to Anna and see if we have any questions that we can address for the participants.
Thank you so much, Mina and Tanya, for that really helpful, information-packed presentation. And some key points that I wanted to highlight is the reminder about the HRSA initiative and the context that as HCH grantees, you are eligible for this additional support. And as we do recognize that going through the recognition process is a labor-intensive project, and oftentimes some of our HCH grantees do not necessarily have all the resources and staff to put together a team and to learn this whole process and then initiate it. So to access resources that are available to us is really wonderful to be reminded, and I encourage all of you to go ahead and do that. The other thing I wanted to highlight was Mina's mentioning to really focus on the most critical factors first, and that's a very good reminder, as well as the Master Record Review Workbook. And thirdly is, as we've spoken about on many of our webinars and training sessions, that HCH care is really not all that different from patient-centered medical home care. We follow many of the same standards, and particularly in the area of patient engagement, as we focus much on outreach to our patients and community. We engage them in terms of self-management through evidence-based guidelines like motivational interviewing. So we have many of these tools in our toolbox already, and so I just wanted to remind us all that we are already doing much of the work now. We just need to collect the data and document it and submit it for recognition. So that being said, I will give you a few moments. We still have some time if anyone has any questions. I don't see any in the Q&A box as of yet. And to remind you about the resources through the National Healthcare for the Homeless Council, we have our annual conference and policy symposium coming up this March in Washington, D.C., and you'll see in the resource slide the link to that, and that is, I believe, the 14th through the 16th. We have multiple publications related to patient-centered medical home, as well as meaningful use implementation. We have 9 steps towards NCQA patient-centered medical home recognition. We have a Healing Hands that is solely focused on pursuing NCQA PCMH, and we have multiple webinars that feature other HCH grantees who have gone through this process, and as Tanya and Mina encouraged, is to really look to your peers who have gone through this process already, particularly like peers, because they may have some really wonderful tips about how they navigated certain challenges and barriers related to the standards. I'm still not seeing any questions. I do have a question that I'd like to put out, and I think for our population, as mentioned earlier, one of our challenges is related to just the transient nature of our population, that the standard of tracking and coordinating care can be one of the more difficult challenges, referral follow-up care. And I wondered if either one of you could speak to any particular suggestions that you've seen other health centers do to try and meet that standard.
Well, you know, the requirement is around having an established process. And it's unfortunate that sometimes patients are not so much lost in the system, but kind of fall out of the system. So if you're documenting that you've ordered a referral, that you've ordered a lab test or an image on a patient, and the requirement is focused on having identified what you've ordered, when you expected to get the result, and to have a process to follow up. And I think it's in that process to follow up that is probably a challenge for your sites if the patient becomes kind of not available. But you are actually going to meet the requirement if you have the process or the steps that you expect the staff to take to look for the patient or look for the result. So, for instance, you have no result back on a lab order that required the patient maybe to go somewhere else for the testing. It's something that you could add to your process to contact the lab for the result or contact the patient. And as long as you tracked your efforts to contact the patient or to find out if they showed up for their referral appointment, or continued to track to see if you could get the referral. I know that's also a challenge for some of your populations. It's that that process structure that actually meets the requirement. And so I'm not probably the authority on how to track down patients and how to track down referrals, but as far as meeting the requirements, if your documentation shows that you've called the patient 3 times or the patient didn't show up for the appointment, you have closed the loop on what that process is. It doesn't mean that we've provided the patient or met the patient's needs, but that does meet those particular requirements.
Wonderful. Thank you, Mina. That brings to mind the webinar that we presented January 31st with Yael Harris from HRSA talking about patient engagement and using technology, and what tools of technology can we implement to help support the tracking and coordinating of care and engaging patients. So I would encourage you to go back if you haven't already listened to that and spend some time looking at some of the technology tools that have been used to help with that, things like Text for Health and other uses of mobile technology, telephonic surveys. So I would be remiss being the HIT consultant to not bring in technology. And it is my understanding, if you are concurrently working towards meaningful use of electronic health records, that meeting the meaningful use requirements really gets you about 50% of the way to the patient-centered medical home recognition process. So they do very much align, and the technology will certainly help in terms of capturing the data and the reporting that you need to do.
Anna, I would like to mention, although the meaningful use requirements, and I'm glad you brought this up, are embedded in the PCMH requirements, you don't have to have completed meaningful use for all of your providers in order to meet NCQA's requirements. We just wanted it not to be something different that you had to do. So if you're on track to do meaningful use and you've got the reporting capabilities, yes, you're going to meet many of the requirements in the program. But I just wanted to mention that they are 2 separate things, and so you don't have to have completed meaningful use to go along to be able to meet NCQA's requirements. It'll simply say, pull a report of at least 3 months that has these patients in the numerator and these patients in the denominator. If you do have a certified EHR, your system will have the capability to do that. Also, that our reports are at the clinic level or the practice level, not each individual provider. So they are aligned, but they are separate.
Thank you for the clarification. And the last resource I'd like to mention is the Safety Net Medical Home Initiative. As Mina had spoken earlier about practice transformation, the Safety Net Medical Home Initiative is a project of 65 safety net health centers that have looked at the transformation process to the patient-centered medical home, and they have some wonderful tools in terms of team building and empanelment, which, as Mina had mentioned, sometimes can be challenges, particularly in the safety net when you have multiple providers, part-time providers, to help with continuity of care. So I would certainly recommend that resource. That's also located in one of the resources on the Council website on the Patient-Centered Medical Home Resource Catalog. So with that, I want to thank you today for joining our webinar with NCQA, and this will be archived on our website at www.nhchc.org within 3 business days. And any questions that we may have addressed, or if any questions that you think of that we weren't able to respond to today, you can certainly submit via email. At the close of this webinar, you'll receive a survey to evaluate the presentation. Please complete it so that we're able to improve your webinar experience. And a link of the archived webinar will be emailed once it is posted to our website. So thank you very much for spending time with us this afternoon. Thank you, Mina and Tanya, for taking time out of your busy schedules to share with us these resources, and I wish everyone a good day. Thank you.
Thank you.